A very good afternoon to everyone. Today, on behalf of the Department of Pathology and Department of Surgery, I welcome you all to today's CPC. For discussion of the case today, we have amidst us a distinguished professor, Dr. Rajdeep Singh, who is Director Professor of Surgery, Maulana Azad Medical College, Delhi. He is also a fellow of the American College of Surgery, as well as a fellow of the Royal College of Surgery, UK. He is the president of Central Zone Association of Minimal Access Surgeons of India. Sir holds a keen interest in laparoscopic surgery, with a particular interest in video-assisted thoracoscopic surgery, GI, and hernia surgeries. He is also responsible for organizing the surgery updates in 2018. To his credit, he has numerous scientific publications in various national and international journals of repute. I welcome you, sir, today. We look forward to listening and learning from you. I now invite you to discuss the case.
Right. Thank you very much for the kind introduction. And a very interesting case today. We have a 25-year-old young salesman, a resident of Pratapgarh, who just had pain in the lower abdomen. And the pain has been there since 3 months. Apparently well since 3 months. Started in the lower abdomen, moved towards the right side. Initially, analgesic would relieve him. Sometimes he would not take an analgesic, but the severity has increased over the past 3 months, so that now he has no relief even with conventional analgesics, no radiation of pain either, no particular aggravating relieving factors, occasional burning, micturition, and all these things were absent: diarrhea, constipation, flushing, no alteration in urinary habits, hematuria. So all of these were absent in this particular case. Nothing special in the past or the personal history, pretty routine. Family history is significant for his father having been operated for a posterior mediastinal tumor, possibly a nerve sheath tumor. We don't know the details for that. Nothing else. In examination, the vitals are pretty normal, except for the diastolic BP being high, a borderline high for a patient who's 25 years old. General examination, systemic examination, nothing particular here, and abdominal examination is also normal. So in investigations, hemogram, pretty normal, KFTs, normal. In LFT, only AST, ALT are elevated, rest are fine. AST about 1.5 times, ALT about 2.5 times the normal. Viral markers are negative and serum chromogranin is also negative. Urine examination, routine microscopic, this culture all are normal. Chest X-ray was normal, part of the routine screening. Now, ultrasound showed an ill-defined hyperechoic lesion of 6 by 3 centimeter at the aortic bifurcation, abutting the right ureter, and there was right hydronephrosis. This was a significant finding. So this is the CT. So running the video, you would see there is definitely right hydronephrosis. So pardon me, sir, if I can see the ureter actually going up here. Up means anterior, and this is the mass which is coming up, and beyond that the ureter is going back down to its normal position again. So it appears as if the ureter has been pulled to one side. So this is the mass which is present. So as I read it, I definitely would be wrong. There's a bowel next to it, but there is no features of obstruction which I can see, and I've already shown the ureter. The size is approximately the same, about 3.5 to 5.5 centimeters, right, in this cut. So Dutta PET CT had also been done, and so running down, that will be the thyroid coming up here, and then the liver and spleen would come up, the liver, then the spleen, and this is the kidney hydronephrotic. The ureter, as you can see, the ureter is going up very well, going up to the mass over here. As I read it, it's not a very strong uptake of Dutta in this particular lesion. I may be wrong here, but as far as I can see, it's not a very good uptake over here. That was a bladder, and the rest was definitely normal. So, sir, what I tried to do was a fusion of the two. This is the first time I was doing it. I don't know if it was correct or not. So this is the fusion image, and the ureter again going up, and in the mass. So all these are the small bowel, it's not the liver or the spleen here. So some scattered uptake here, it's not like a very avid lesion as we would expect in a neuroendocrine tumor. So my interpretation, it's just an irregular lobulated mass just below and in front of the aortic bifurcation. I could appreciate a structure passing through the mass, which I thought it probably is some vessel. A mesenteric vessel is likely. Right ureter is pulled medially. It's not like a mass pushing it towards one side. It's being pulled medially with hydronephrosis. No bowel dilatation, no lymphadenopathy. IVC specifically and the aorta also is not involved or they're compressed, and it's not avid on DOTA. So summary history exam investigations, progressively increasing dull lower abdominal pain. Now pain has got so many causes, even if it's a dull pain, could be inflammatory, could be neoplastic. But what we know, it's not an acute onset pain, so probably it's a slowly progressive disease which is worsening over time. That's what we can say. Mildly deranged AST, ALT, so far we have no evidence why this should occur. There is no like a biliary dilatation or features of obstructive jaundice here, cholangitis. Abdominal examination is absolutely normal, and there is a approximately 6 centimeter mass in front of the aortic bifurcation. So many inflammatory causes, tuberculosis is one of the mimickers in nowadays as far as various diseases concerned, but here I would really not consider tuberculosis. Bowel appears normal, there is no obstruction, the lesion is separate from the bowel or adjacent to it. There are no diffuse nodes, so I would not really consider that. There are reports of like a fishbone perforating the bowel and causing a localized abscess, but here it's not an abscess, it appears to be a fully solid mass there. Retroperitoneal fibrosis, IgG4, paniculitis has a very acute onset. So because this was a gradual insidious onset, I'm not considering paniculitis here. And sclerosing mesenteritis has got widespread lesions throughout the retroperitoneum. In neoplastic, could be carcinoid, extraintestinal cyst. Lymphoma usually would have multiple lymph nodes. They would not aggregate to each other. So that's why I've not kept lymphoma in my discussion. Paraganglioma, neuroblastoma is in a very younger age group. This is not the age group where it would present. Schwannoma, sarcomas I was discussing. The examination of testes is one issue was not clear, but I presume it was normal. Secondly, if it was a metastasis from the testes, they would primarily go to para-aortic or paracaval nodes, not into the pre-aortic nodes, that too at the bifurcation level. So again, I would not consider this. So considering the inflammatory disease first, one is an IgG4 related disease, can affect a lot of organs, sites as described here. One of the sites is retroperitoneal tissue, where it would usually cause retroperitoneal fibrosis. Now, as we know, fibrosis would tend to pull the ureter towards it. So that is one of the differential. The point against it is that it usually has periaortitis, that is, it encases or is present all around the aorta and the IVC, which is absent in this particular case. The fact there was no fever leukocytosis is in its favor. They usually have back pain, but they may have abdominal pain also. That depends on the site also. But the one point is that the presence of autoimmune hepatitis is there in IgG4 related disease, and AST/ALT were elevated in this case. But mind you, even in IgG4 related autoimmune hepatitis, ALP, alkaline phosphatase, is elevated in 100% of patients, which was not there in this particular patient. Could it be a carcinoid? Usually in a bigger, increased age group. We all know they have typical symptoms, but any carcinoid which is draining into the portal system would not have those symptoms initially because they are inactivated by the liver, unless their widespread liver mets are present. They cause an intense desmoplastic reaction. So that also may cause pulling of the ureter to one side and cause a kinking of the ureter and therefore hydronephrosis. But on the other hand, they have a high chromogranin A and they are DOTA not avid lesions. Extraintestinal cyst has been reported for various sites, even from the anterior abdominal wall. So totally separate from the bowel. In this, they are usually well demarcated lesions. They don't invade and they are usually painless unless they grow to so big they are compressing surrounding structures. So I really would not consider extraintestinal cyst any further. As soon as the site is there, it's front of the aortic bifurcation. The first thing which comes to mind are the organs of Zuckercandy. And they are the termination of the sympathetic chains from both the sides. They combine and they are present over there. Not always in front of the bifurcation, anywhere below the origin of the inferior mesenteric artery. And they can cause non-specific pain. If they are well-defined lesion, they may also be hereditary. So because his father also had a lesion which we really don't know what the cause was, they may be hereditary. But they do have a high chromogranin A serum levels, and Dotanok has a high sensitivity. For schwannoma is very common condition described from many places, as well as the abdomen. But retroperitoneal schwannomas are less common, but hereditary variants have been described. So again, this is a point because his father had this, and we know that most of the posterior mediastinal tumors are going to be neurogenic in origin. Maybe this was a schwannoma also. Because nerve fibers don't pass through the schwannoma, they usually don't have pain, but when they become large, they can compress the nerve and then cause pain. And chromogranin A rises, but it's not the same level as neuroendocrine tumors. For NETs, it may go up to 300 levels. For schwannomas, it could be about hundreds, whereas the normal is about 85 to 90. And on PET scan, depending on the cellularity, it may be very poor uptake or a very good uptake. So the PET scan is not at all specific for schwannoma here. Sarcomas may be there. So whenever we talk about retroperitoneal tumors, we always consider sarcoma in the differential. But one of them is primary leiomyosarcoma mesentery, but it's extremely rare. They have a large mass and they would invade the surrounding structures. They don't pull the structures towards them. Like in this case, the ureter appears to be pulled towards the mass. They don't pull. They would engulf and invade these structures. And there may be many different types of sarcomas here. One which is unlikely is a liposarcoma because there doesn't seem to be any fat in this CT. So what I have, this is the first, second, third possibility which I have made. Let's see what it turns out to be. Thank you.
That was a very wonderful discussion, sir. I really appreciate your nice algorithmic approach to the case. I now invite any opinions from the audience regarding the case.
So I think one very critical finding that can come from the great. Most of the diagnosis is revolving around imaging. And we have example. Let's see what they felt when they saw that. And also we are
So he's asking about the colored fusion PET image. So when the DICOM dataset is available for the study, then you can generate a fusion colored image from any of the DICOM viewers. So that can be done. So, sir, very nicely described, and just few representative images and what we thought during the course of the disease. So this was the CT which was presented to us. This was a single venous phase contrast enhanced CT of the abdomen. So we could see this was a very well demarcated homogeneous appearing mass. There was no calcification, no necrosis, no fat attenuation. And it was anterior to the aortic bifurcation. So it was not actually retroperitoneal. We interpreted it to be more of mesenteric in location and anterior to the aortic bifurcation. Then there was right hydroureteral necrosis, which was rightly picked up. This is the location of the lesion on the sagittal image. In addition, there was another interesting finding in this patient that we can see that the small bowel loops were located on the right side of the abdomen. The large bowel loops were located on the left side of the abdomen. The SMB is located anterior to the SMA. So there was clearly malrotation of the gut, and on following the bowel loops, we could actually see that colon was present in the central abdomen, the cecum. So the cecum started from here, then ascending colon went up, then there was this transverse colon, then descending colon. So it was almost like complete non-rotation of the gut, which was there. This is to show the altered relationship of the SMA and SMV. So normally SMV is expected to the right of SMA. Here it is coursing to the left of SMA. So there was definite non-rotation of the gut. And this is the mass lesion. As we can see, there is a lot of desmoplastic reaction. There is a lot of scirrhous margins of the lesions. And it was homogeneous. And this is the hydroureteronephrosis, which is there. So we thought it was mesenteric mass lesion. It was causing obstruction of the ureter. And there was presence of malrotation. So with this scirrhous reaction and mesenteric location, the first thing which comes to mind is a carcinoid, that is a neuroendocrine tumor. The problem was we were not able to identify any bowel primary because majority of these mesenteric entities will have a bowel primary and this will be nodal. But we could not identify any bowel primary. Second problem was it didn't show much of enhancement. It was only mildly enhancing. So anyways, we suggested serum chromogranin and Dotanoc PET, and as we know, both were normal. So there was no elevation. So other than that, homogeneous lesions, we could, and in the mesentery, we could think of two lesions. One was a mesenteric gist and mesenteric desmoid. Those were the things which came to our mind once we knew that chromogranin and Dotanoc are negative. So desmoids are homogeneous lesions, so they can. Sir, that will happen because very irregular margins were also there. They will also cause desmoplastic.
Hands a lot. All those features are majority of carcinoids in hands. When you see a given case with this kind of an appearance in the mesentery, our first possibility, as yours also, was. And very often what Ankur was saying, that there should be a bowel primary. The bowel primary we know are so small that they are very often missed, and we just pick up the mesenteric deposit rather than the neuroendocrine tumor itself. Of course, Dotanoc here was negative. So.
And so we see a lot of carcinoids and we treat a lot of carcinoids too in nuclear medicine. And I think mesenteric carcinoids in themselves are a separate entity. You wouldn't find a primary many a times. The treatment, however, remains the same. So my just point to clarify was that we should not necessarily say that this is a nodal.
Thank you.
Any other comment from the house? So we received 4 specimens. As you can see from the requisition form, the basic history of the patient was provided, that he is a 25-year-old male. He complained of pain in the abdomen for the past 3 months, and he had the right, which was there. Sorry. There is अच्छा सर
Next, for so for the radiological evaluation and clinical suspicion, we went ahead with the exploratory laboratory. As Ankur has already told, the primary diagnosis for us was carcinoid or some mesenteric mass. However, we are also not sure about the gut malnutrition. So that was also intraoperative findings for us. Intraoperatively, we found that cecum was in the midline and the ascending colon was also midline, and just on the transverse mesocolon, on the mesentery, there was a mass which was in front of the aorta and IVC. And the ureter was also grossly adhered to it. So we have to transect the ureter first then excise the mass in toto. In that course of event, we also found that inferior mesenteric artery was also been already pulled into the mass. So we have to ligate and divide the inferior mesenteric artery also. So we have already sacrificed the right ureter, divided the right ureter, inferior mesenteric artery. Then the mass could be separated from the retroperitoneum. After that, we did a right hemicolectomy, formal right hemicolectomy, and did an iliotranverse anesthesia, so that the mass was in the mesocolon, which can be excised into. And postoperatively, patient behaved well, and he was discharged on 6 postoperative day. And there was extensive adhesions intraoperative also. There was significant amount of desmoplastic reaction. Even the left ureter also apparently tethered with the mass. But since we already have divided the right ureter, we save off the mass from the left ureter. But however, besides that, it was the adhesions with the retroperitoneum as well as the surrounding was very dense. It took almost 3 to 4 hours to separate the mass from the underlying vessels as well as the retroperitoneal structures. Yeah. So at the end, we anastomose the ureter with end-to-end anastomosis with stent in situ. No, there was no latch band. The malnutrition was complete malnutrition. Even the mesocolon, there was no shortening of mesocolon, or even the mesenteric oiling was not required because mesentery was also white, and it was a complete mesocolon from the beginning, malnutrition from the beginning. So entire DJ flexor was on the right side, and the whole colon is on the left side of the abdomen. Yes, it was adherent to the colon, sir, because it was just the size of the medial border of the ascending colon. No, because colon was already on the left side. We did a right hemicolectomy. The terminal bowel of the IAM as well as the transverse IAM, right 1/3 of the transverse colon was excised along with the ascending colon and the mass.
So we received 4 specimens. The main specimen was sent as mesenteric mass with right hemicolectomy, along with 3 additional specimens which were labeled as tumor tissue, along with the ureter and involving the vessel. So as has been discussed earlier, the mass was avid on dotonic scanning, and the clinical differential was that of a possible neuroendocrine tumor. So this is the gross image. As you can see here, it seems to be an infiltrating mass. It appears to be grayish white and partially circumscribed. This is the ileocecal junction, and the mass appears to be arising from the mesentery and infiltrating into the adjacent colon. So this is an image from the section which was taken from that area. Now it's very helpful to delineate the relation of this tumor with that with respect to the colon wall. As you can see, we can see here the muscularis, the mucosa, the submucosa, the muscularis propria, and the subserosa of the colon. So apparently the mass is infiltrating from the serosal aspect as was seen grossly and infiltrating up to the subserosal aspect of the colon. And this is a lymph node here, and this is a very low power view. So this is a high power view. As I've been seen earlier, here we can see that it has an infiltrative border. So you can see the tumor cells, it's a spindle cell tumor which is dissecting through the adipocytes of the subserosa. Now, as you can see, the tumor cell is basically, it's a spindle cell tumor which is arranged as long sweeping fascicles. So for the juniors who are here, long sweeping fascicles means that it is arranged in a all the fascicles are very long, which are following a regimented behavior, and we have different directions the tumor cells follow, as a result of which they seem to be intersecting with each other, which can be seen from this image. So on a high power view, we can see that the elongated spindle cells are arranged in parallel fashion, which can be simulated or likened to that of the movement of a school of fish in a one direction. There were multiple thin-walled dilated vessels, some of which can be called as Tacon vessels also. Along with it, what was interesting was that the presence of a collagenous stroma, and in the right-hand side, we can see that this collagen formed ropey collagen with formation of clear bundles, which can be likened to colloidal bundles of collagen. So there were other cellular areas also which had a typical tissue culture pattern. However, what was interesting was that the mitotic figures were very less. An occasional mitotic figure was present, hyperchromatia, atypical microsis, necrosis, etc. All other features which delineate a sarcoma were absent. And on clear image, more high power view, we can see that the nuclei are oval and they had a pinpoint nucleoli. So this was the mucosa of the adjacent colon. It appeared fairly normal and was histologically unremarkable. These are the proximal and the distal resected margins which were free. The appendix showed features of recurrent appendicitis. The 18 lymph nodes were dissected, all of which were free of tumor, some of which showed features of sinus histiocytosis. This was what is sent as tumor tissue over the ureter. Here we can see a large vessel, and adjacent to it, we can see a tumor in the perivascular area. This was sent as separately as tumor tissue. Similar fragments of similar looking tumor. On a high power view, we can see that there are some nerves which are entrapped within this tumor. So this is a tumor with an involved vessel. We can see clearly that in the tumor is infiltrating into the vascular wall. So the key histological features is that it's a poorly circumscribed infiltrative tumor with presence of elongated spindle to stellate-shaped cells which were arranged as long sweeping interlacing fascicles. There were numerous thin-walled dilated vessels with presence of perivascular microhemorrhages. It was variably hyalinized with presence of variably cellular areas. Dispersed colloidal collagen was there. The cells were wavy, spindle set, harboring tapering or somewhat pointed like ends. The cells also had indistinct cytoplasmic borders, ovoid nuclei, and a pinpoint small nucleoli. The tumor had mild to minimal nuclear pleomorphism with presence of occasional mitotic figures, and all other features which are typical of sarcomas were absent. With this, we came to the following differential diagnosis, out of which the first was fibromatosis, followed by sclerosing mesenteritis, then mesenteric gist, an SFT, inflammatory fibroblastic tumor, and lastly, a leiomyoma. So, as there are lots of residents here and they are in different stages of learning, I will discuss one or like a short of all the differentials so that they can also form an opinion about the case. So, a leiomyoma in gist, we can say that it's a benign mesenchymal neoplasm showing a smooth muscle differentiation, occurs in the muscularis mucosae. So, one thing which is interesting is that in the colon and rectum, it is seen to arise from the muscularis mucosae rather than the muscularis propria. It is fairly well circumscribed, which goes against our index case. On histopathology, what was against was that the leiomyoma usually have a blunt-ended nuclei, unlike ours, which had a tapered nuclei. Leiomyoma also lacks the collagenous stroma, which is very distinct in our case. Immunohistochemistry-wise, leiomyomas are SMA, desmin, H-keldosmon, and calpain positive. Some cases of leiomyomatosis may be familiar, and this was interesting because this patient's father had a history of excision of an MP history or so. So maybe we wanted to know if it followed any syndromic course. So next differential was that of an inflammatory myofibroblastic tumor. Again, it is a fibroblastic tumor, neoplasm of intermediate biological potential. The small intestine and the colon are the most involved primary GI sites. Epithelioid IMT has a marked predilection for the mesentery, but here our cells do not look epithelioid as such. But though the age group of IMTs favored our case because ours was also a young patient, and IMTs are also known to occur in young patients. So histopathology-wise, we could see some loose fascicles of uniform plus spindle cells with vesicular chromatin, small nucleoli, and pale cytoplasm. What is absent in the case was a typical inflammatory background, which gives the tumor of IMT the typical name of inflammatory myofibroblastic tumor, comprising of lymphocytes and plasma cells. Immunohistochemistry-wise, these tumors are mostly ALK positive, and they are also positive for SMA and desmin. The third differential which we had was that of the solitary fibrous tumor. It's again a fibroblastic tumor which is characterized by thin-walled dilated vasculature. Now, this may arise at any anatomical location, including the small bowel mesentery as was in our case, and the serosal surfaces of stomach and the colon. It's primarily seen in a wide range of patients ranging from 20 to 70 years. So it still can be a differential in our young patient of around 25 years. However, it is well circumscribed, unlike our case, which had an infiltrative border. Histopathology-wise, it has got that staghorn-shaped vessels, a ropey collagen, which goes well with our case. The SFTs, however, are characterized by a standard NAT2 STAT6 fusion, which can be detected by the STAT6 immunohistochemistry. Majority of SFTs behave in a benign fashion. However, approximately 10% of cases behave aggressively. Then we have another differential, which was a mesenteric gist. Now, this is a mesenchymic neoplasm arising from the interstitial cells of Karl. 10% of cases are supposedly primary disseminated, and apparently the site of origin cannot be established. Extra GIT mesenteric gist occur predominantly in the mesentery, omentum, or the retroperitoneum. However, this patient's peak during the 6th decade of life, which was again against our index case, who was of 25 years. They are again well circumscribed masses. Then mesenteric gist also shows extracellular collagen globules, which are otherwise known as sphenoid fibers, and as can be seen in the picture, they are immunopositive for CD117, DOG1, etc., and harbor KIT or PDGFR mutation, and sometimes they can also show alteration in the SDA subunit genes. The other possibility was that of a sclerosing mesenteritis. As you can see here in this picture, here it shows sclerosing mesenteritis often show an infiltrated border, which was like similar to that which is seen in our case. It's an uncommon diagnosis, however, and it is possibly underdiagnosed. Most commonly, it is seen in the population of Peru. Small bowel mesentery is involved more commonly than the colonic mesentery. Although it is thought to be usually idiopathic, but it is a subgroup of cases are also seen to be associated with the IgG4 related diseases. It occurs in men with a median age of 65 years, and the clinical presentation may vary from a large solitary mass or multiple lesions or diffuse mesenteric thickening. Typically, 3 different findings are found, which is fibrosis with dense collagen, which was there in our case, fat necrosis, which was absent, along with presence of chronic inflammation and variable focal calcification. The presence of minimal ATPR, few or no mitosis was similar to what was seen in our case. If this case belongs to the, or if in a sclerosing mesenteritis forms a part of the IgG4 cohort, then the plasma cells can be seen, which stain for IgG4. So various medications can be used in these cases, including corticosteroids and surgery, depending on the clinical severity. The last possibility was that of a desquoid fibromatosis. It is also known as an aggressive or a deep fibromatosis. It is locally aggressive myofibroblastic neoplasm with an infiltrative growth pattern, which was clearly well delineated with what was seen in our case. Intra-abdominal cases most often occur in the mesentery of the small bowel, followed by the mesentery of the ileocecal region, as was in our case. Now, most patients present with asymptomatic abdominal mass, plus minus bleeding and pain. Age range is broad, however, the peak is seen in the 3rd decade of life. Although most cases are sporadic, 10 to 15% cases are also associated with fat. Usually, they are large masses as large as 10 centimeter in diameter with a whorled cut surface, as was seen in our case. On histopathology, long vesicles of myofibroblasts can be seen, and these tumors are usually nuclear beta-catenin positive. With this short summary of all the differentials, I would like to open the case now to the House for any possible clues regarding the diagnosis.
Melody doesn't like to usually got a differential because it was very localized and whatever we have seen it involves the
Any other diagnosis? Single diagnosis. So with this, we proceed to the IHCs. Okay. So first, Desmin myogenic and smooth muscle antigen or SMA labeled smooth muscle cells. So usually a leiomyoma, which is a smooth muscle tumor, would expect a diffuse SMA positivity, which was unlike here, what is seen in this case. Here, occasional myofibroblasts are seen to immunostain for SMA, exhibiting a typical tram tract appearance, which can be likened to the tract or railway track appearance, which is described in case of described in cases of other myofibroblastic tumors rather than smooth muscle tumors. So with this positivity for SMA, leiomyoma was ruled out. Yes, important. Not things of. Then, as you know, it is called anaplastic lymphoma kinase. So, with tropomyosin, it forms a fusion surrogate which is detected by IFC, and it's immunopositive in most cases of IMTs. So, as ALK was negative, inflammatory myofibroblastic tumor was also ruled out. Then we have CD34 and STAT6. So, as I mentioned earlier, SFTs are characterized by a classic NAT2 STAT6 fusion, which is immunohistochemically detected by its surrogate marker STAT6. They are also CD34 positive, as both these immunohistochemical ICs were negative. Therefore, SFT was also excluded. Then next we have CD117, that is KIT or DOG1. As the name suggests, this is very specific for GIST. And since both were negative, so GIST was also excluded. Then, since the patients had a father in the history of MPNST, we did also a SOC stent ruling out any neurofibromatosis, although the morphology did not appear to be suggestive of neurofibromatosis. A MUC4IHC was also done to exclude a low-grade fibromyxoid sarcoma. Then beta-catenin was done, and beta-catenin, as you can see here, it showed a strong nuclear positivity characteristic of an aberrant expression. So based on this, desmoid fibromatosis was the diagnosis. The Ki-67 labeling index was less than 1% in the areas of highest proliferation, and androgen receptors were also positive in few of the tumor cells, which is also seen in case of desmoid fibromatosis. So final diagnosis was desmoid fibromatosis. So a brief oversight into the desmoid fibromatosis. The term desmoid comes from the Greek word desmos, which means tendon-like. In the ICD-11 coding, they had been placed under neoplasms of uncertain behavior of connective or soft tissue. They are relatively rare, comprising about 0.03% of all neoplasms. Median age is around 37 to 39 years, with a slight female predilection. Now, subtypes, we have extra-abdominal desmoid and abdominal fibromatosis. Extra-abdominal ones comprises of around 30 to 40% of cases, with the primary site being the musculature of the shoulder, followed by the pelvic girdle. And around 5% of extra-abdominal fibromatosis are, however, found to be multicentric. The tumor is most often always confined to the musculature, and they might sometimes have, since they are infiltrated, they may infiltrate into the overlying subcutaneous tissue or the underlying bone, causing bony erosion. The next is abdominal fibromatosis. These tumors usually arise from the muscular aponeurotic structures of the abdominal wall, especially the rectus and the internal oblique muscle, and their facial coverings. They comprise 20% of all cases. They have a strong propensity to occur in women of childbearing age. However, rare examples can also occur in children of both genders. They usually remain in the site of origin and do not cross the midline. Intra-abdominal fibromatosis can be divided into further pelvic fibromatosis and mesenteric fibromatosis. They comprise about 15 to 20% of all cases. Pelvic fibromatosis based on its location in the iliac fossa and the lower portion of the pelvis. They manifest as a slow-growing palpable mass. They may encroach on the urinary bladder or the rectum, causing hydronephrosis. The tumor usually arises from the aponeurosis of the muscle tissue. Occurs chiefly in young women who are 20 to 35 years of age. However, this is unrelated to gestation or childbirth. Now, pelvic fibromatosis very often mimic a tumor, as can be seen in various case reports in which a desmoid type of fibromatosis have mimicked a uterine myoma and had invaded into the urinary bladder. Now, mesenteric fibromatosis forms the most common primary tumor of the mesentery, accounting for approximately 8% of all fibromatosis. Most cases are sporadic. However, some may be associated with familial adenomatous polyposis syndrome or Gardner syndrome. Others have a previous history of trauma or can be seen in case of hyperestrogenic states. Most often it occurs in the mesentery of the small bowel, but some originate from the ileocolic mesentery or the gastrocolic ligament. Patients often present with an asymptomatic abdominal mass. The masses are quite large at excision, accounting for approximately 10% or more. And the complications which may follow can be like compression of the ureter or development of a ureteral fistula. Sometimes it also impinges on the intestine and cause intestinal perforation. So molecular pathology, so as you can see, the genetic, endocrine, and physical factors like trauma, hyperestrogenic state, and a predisposition due to some syndromes seem to play an important role. So majority of 90 to 95% are sporadic and result from 3 different point mutations in exon 3 of the gene that encodes beta-catenin, that is CTNNB1, out of which the exons 41 and 45 are the most common mutations seen. A smaller percentage, however, can be seen in Gardner syndrome and results in germline mutation of the APC tumor suppressor gene. Whether this is due to an activating mutation of CTNNB1 or a suppression mutation of the APC gene, both interfere with the beta-catenin proteasomal degradation, resulting in nuclear accumulation of beta-catenin, which can be detected by immunohistochemistry. This causes downstream activation of the WNT beta-catenin pathway and drives the further tumor genesis. A subset of desmoids also harbor trisomies for chromosome 8 and or 20. So mesenteric fibromatosis in Gardner syndrome. So this was first described by Gardner, who reported the familiar occurrence of polyposis, osteomas, fibromas, and cyst, and subsequently the term Gardner syndrome was coined. So what is interesting is that 10 to 15% of patients with a Gardner syndrome or FAP have got an 8 or 100-fold increase, which is a quite significant increase for developing fibromatosis. And in one study, around 70% of FAP patients who had abdominal surgery for excision of the diseased portion of the intestinal tract had fibromatosis later on. This was also reflected in a meta-analysis of 10 published cases in which a positive family history of a desmoid tumor was the only factor which was predictive of the development of these lesions in patients with Gardner syndrome. So, as our case had a Dotanov, it was Dotanov uptake on Dotanov PET-CT. So, literature search revealed that fibromatosis sometimes mimic relapse of a neuroendocrine tumor, and this case would imply that the tumor cells of fibromatosis showed a surface expression of somatostatin receptors, particularly of somatostatin receptor 2 and 5, for which this 68G Dotanov has affinity. And this, I wanted to follow up and see that if this has got any therapeutic value. And so on literature search, there was a short communication which was published in British Journal of Cancer, in which a group of 10 patients were evaluated, and when every other therapy was ruled full exploitation of standard therapy, and this patient did not respond to any surgery or any radiotherapy, they tried giving him peptide receptor radiotherapy, and this patient responded. And as can be seen that both patients had a protected clinical benefit with this peptide radiotherapy in the absence of acute and late toxicity. However, since these are very isolated case reports, this needs further exploration. So, from the morphological spectrum of desmoid fibrosis, there are different histological patterns which can be seen. This can be conventional, hypocellular or hyalinized, staghorn vessel, myxoid, keloidal, nodular fasciitis-like, or hypercellular. So, all these patterns can be seen in both intra-abdominal or the extra-abdominal fibromatosis. However, intra-abdominal ones most commonly show the conventional pattern. Now, pathological and ancillary findings. Morphological findings are essential in all anatomical locations. However, it was found that intra-abdominal fibromatosis showed a dominant keloidal collagen and staghorn vasculature pattern. Gardner-associated fibromatosis had a prominent myxoid matrix. Now, there is no mitotic cutoff distinguishing fibromatosis from a sarcoma, and the distinction has to be made only on architecture and cytology. Apart from that, immunohistochemistry-wise, various other IHCs have also been described in fibromatosis, which include LAF1, CD117, then cyclin D1, calretitin, and all the sex steroid hormone receptors like ER, PR, and AR. So if we differentiate, now as there is a controversy because CD117 is originally described to be expressed by tumor cells of GIST. However, there have been various studies by Montgomery and Yepnis et al., who are prominent GI pathologists, who suggested that in their case series, CD117 was also expressed in fibromatosis. And since sometimes they form a morphological differential, specifically in the case of mesenteric GIST versus a mesenteric fibromatosis, it always becomes a confounding factor as to diagnose whether this is a GIST or a fibromatosis in the absence of a nuclear beta-catenin positivity. So morphologically wise, it is seen that usually a GIST will have a growth pattern which is formed of organoid vesicles and variable with high cellularity, presence of hyalinized vessels, absence of colloidal collagen, however, presence of sphenoid fibers with presence of necrosis and a pushing margin, unlike the infiltrating margin which is seen in case of your mesenteric fibromatosis. So immunohistochemistry wise, however, there has been always contradictory reports, and Enzinger et al., however, has claimed that maybe the other reports of CD117 positivity in mesenteric fibromatosis was due to a use of a different clone. And so the classic way of teaching is a CD117 dog1 are immunopositive in GIST, whereas your beta-catenin is positive in case of mesenteric fibromatosis. The prognosis-wise spontaneous regression is observed in sporadic cases, particularly in menarchal and menopausal women. The rate of local recurrence is slightly lower than that of extra-abdominal lesions. Lesions are to occur within the first 2 years after initial excision or in connection with subsequent gestations. Now, patients with a Gardner syndrome will have more recurrences. Interestingly, it is found that a microscopically positive surgical margin did not predict a recurrence rate. Post-operative radiation therapy is often used in situations where a WLE cannot be performed, along with other modalities of treatment like TKI inhibitors, anti-estrogenic receptor therapy, utilizing hormone receptor analogs, though not fully established, appears to be promising. So to summarize, this is a fairly rare tumor. Clinical imaging features often may mimic invasive tumors or a neuroendocrine tumor, as was seen in this case. Histopathological evaluation and immunohistochemical analysis is thereby imperative for your diagnosis, and the occurrence with FAP or Gardner syndrome in a subset of cases warrants a thorough evaluation for excluding any syndromic association. With this, I conclude, and I would like to acknowledge and thank you. I'm grateful to the Department of Surgery, Department of Radiology, the Surgical Histopathology and Immunohistochemistry Lab, Dr. Rachna and Dr. Anubhav, who had primarily worked up the case, Professor M.C. Sharma for allowing us to do beta-catenin in his neuropath lab, Dr. Achal Kakkar and Dr. Arshit Tindal, who helped in the smooth conduction of the CPC. Any other comments from the clinical team?
So one of the things is nowadays in desmoid, especially of abdominal wall, we have a good medical management. We had a patient with immediate postpartum care. She presented with a huge abdominal, and if we were to resect it, she would have lost her abdominal wall completely, and there wouldn't have been any possibility of reconstruction. We spoke to our med colleagues, and they put her on anti-inflammatory and tamoxifen. And the tumor has over 2.5, 3 years disappeared. So I was talking to Dr. Sandeep Bakshi the other day. They were saying that primarily they think that this might, unless it's an easily resectable thing, the medical manage it medically. So that is one thing probably good that has come out. Even targeted therapies now. Otherwise, long time back we used to use tamoxifen and all. I think mediastinal desmoids. We have seen recuperatory desmoids and all. I think now we have a little more medical, in unresectable situations, medical therapies. So these are always challenges. We have operated on the saying that in masquerade, and we had a young girl presented with, everybody thought it's an esophageal malignancy, and eventually after esophagectomy it turned out to be a desmoid. So they can mimic and they can be difficult to. I'd like to congratulate the operating team and the Department of Pathology for wonderful surgery and coming to a conclusive diagnosis.
Thank you, sir, for your comments. Any other comments from the House?
So, can you pick this up on core-needle biopsy pre-op?
Sorry, sir.
Core-needle biopsy, if it was done pre-op? And secondly, would it have changed management? Not in this case because the ureter was involved, but if ureter was not involved, would it have changed the management if you know the diagnosis pre-op?
First question, core-needle biopsy, yes.
So you will be able to diagnose
picked-
on a CNB, core-needle biopsy also.
Yes, sir.
Did it have changed the management?
Though it's a difficult diagnosis, I would say, but I think with a nuclear beta-catenin positivity and
biopsy in this location. Doing a biopsy in this location.
Made on biopsy.
And plus doing a biopsy in this have been very, very.
It was surrounded by power loops, so it could not have been done safely. It was also discussed whether starting with biopsy process or not. Those things were also discussed.
But at the end of the day, if we can resect without compromising the safety of patient, that many a time. P was not done. I don't think colon was anywhere. No, there are.
So I would like to make a short point. Firstly, congratulations for an excellent review. I think if you are able to reach yttrium 90 Dotanoc therapy in your review, you have done a wonderful job. That's point number one. Short teaching point for students present here is that this therapy, which we call as PRRT or peptide receptor radionuclide therapy, the cardinal principle is that the tumor should show uptake at least equal to or more than liver. So there is a scoring system for this. Now, I haven't seen the image that you showed. I joined in late, but from what I could read from the report, it was written that there was mild expression and no definite evidence of SSTR expression. These are the candidates who will not benefit from PRRT, although that remains as an option.
thank you, sir, for highlighting that.
I don't know. Whenever we start understanding any classification, the pathologists change it. Negative. Now it's
Sir, in this case, there was no uptake. There was no uptake, and we excluded the neuroendocrine tumor. And actually, that may be the case report in which she has shown that the desmoid tumor may show SSRT expression, but mostly they are negative.
That for us, the problem is
so much is the variance.
You are polite, sir. No, sir, you are polite in this case. Sir wanted to say whatever radiologist and nuclear medicine physician has told, that turned out to be something else other than that. And you have not acknowledged nuclear medicine people. We have done the gallium glutamac in this patient.
Sorry, sir. Sorry.
I'm just joking. On the
Sorry,
lighter
sir.
note.
Special thank you to you now.
I'm just joking.
Thank you, everyone.